Hello, my name is Jay Huang. I'm a PGY4 pathology resident in the United States. I go over cases almost on the daily from the head to the toe across all organ systems. So if you're interested in that, please give a like and consider subscribing. Without further ado, this is thanks to UPMC and the pathology unknowns. Today we're going to focus about head and neck pathology. This is case 1104. We have a female in her early 50s presented with a parotid mass. The patient underwent excision of the parotid lesion at an outside institution. Gross examination consisted of a 2.7 by 1.8 by 1.3 centimeter portion of salivary tissue, 4 grams, and revealed a 1.5 centimeter multilocular cystic lesion containing mucoid material. So maybe it could be a mucocele, it could be a mucoepidermoid carcinoma. Slides were reviewed in consultation. Microscopic examination revealed a multilocular cystic lesion. So here is figure 1. Sorry I can't zoom maybe a little bit closer, but without as good resolution. We see this multicystic lesion that has somewhat of maybe a pseudocapsule here, surrounded by regular parotid parenchyma. The cysts demonstrated an attenuated single to double layer of oncocytic cells with surrounding pericystic sclerosis and stromal lymphoplasmacytic infiltrate, figure 2A. So let's look at figure 2A right here. All right, we see some oncocytic-like cells, somewhat ciliated with the fibrous pseudocapsule, lymphoplasmacytic infiltrate. And mucus cells were present and prominent in some areas. So let's see. Oh yeah, here you see the mucocytes. So we have like epidermoid cells, we have mucocytes. Foci of architectural complexity were also focally noted, consisting of daughter cysts, figure 2C, as well as papillary tufting with nuclear stratification, somewhat interestingly with rare cilia, figure 2D. All right. So we can see like a daughter cyst, as they had mentioned, with maybe suggestion of a papillae here with a fibrovascular core. And then here we delve closer, and it looks like they have like little cilia slash like cytoplasmic blebs. But we see the mucocytes here. We see the epidermoid cells that are oncocytic. Whoops, sorry. All right, so the case showed no perineural or angiolymphatic invasion, nor was there necrosis or mitotic activity. So this most likely is a mucoepidermoid carcinoma. Low grade tend to have more mucocytes. This one didn't have as much, and high grade should have less mucocytes and more like epidermoid cells. So, but this one, the cytology was not as bizarre. So this was a mucoepidermoid carcinoma, low grade with oncocytic features with cilia. So if you're not sure, you can get a translocation study, 1119 CRTC1 mammal 2, and it was mammal 2 was positive for rearrangement by fish. Let's talk about, there's a lot. Wow, okay. Well, let's talk about mucoepidermoid carcinoma. It's the most common salivary gland malignancy and is histologically comprised of mucus cells, intermediate cells, and squamoid epidermoid cells, but also may demonstrate clear cell or oncocytic, which we saw in our case, or columnar cells. Approximately half of mucoepidermoid carcinomas occur in major salivary glands, predominantly in the parotid gland. Most MECs harbor a tumor-specific translocation at translocation 1119 expressing CRTC1 mammal 2 fusion gene. While most oncocytic mucoeps with lymphoid stroma, like Warthin-like, raise Warthin tumor as a differential diagnostic consideration, here, given the attenuated, almost single-layered appearance of the majority of the lesion, lymphoepithelial cyst is a closer differential diagnostic consideration. In contrast to this mucoep, lymphoepithelial cyst tends to be more squamous with only rare mucus cells. In lymphoepithelial cysts, the epithelium is often infiltrated by lymphocytes rather than surrounded by sclerosis with lymphoplasmacytic infiltrates. Cyst adenoma of salivary gland is another entity in the differential diagnosis and may show a lining similar to that of this case. Although mucinous subtype is uncommon, it may mimic a purely cystic mucoepidermoid carcinoma. Cyst adenomas, however, lack invasive growth and also lack complex arborizing and hierarchical papillary tufting, which we saw a focus of with the daughter cyst. Ciliated epithelium is not uncommon in mucoeps in our experience and likely underreported given the recent interest in this topic, though it is only rarely prominent. Thus, ciliated epithelium does not automatically equate to a benign diagnosis. Finally, the impression of mucoep was confirmed by the fluorescence study for mammal 2 gene rearrangement. Mucoepidermoid carcinomas are currently graded using a 3-tier system as low, intermediate, and high grade based on a constellation of cytomorphologic and architectural features including cystic component, border, mitoses, anaplasia, perineural, and angiolymphatic invasion, among others. Grading in mucoepidermoid carcinoma is important for prognosis and therapy. The reported 5 years overall survival rate for low-grade MEC is 92 to 100%. So in this case, this patient probably has a great prognosis rate. Low-grade MECs generally require only surgical treatment, while high-grade MECs require adjuvant radiation and neck dissection. There are different grading systems that have been adopted for mucoeps, and the 4 most popular grading systems, yes, there are 4, are AFIP grading system, modified Healy system, Brandwein system, and MSK grading system. Both the AFIP and Brandwein systems are point-based, with each adverse histologic parameter being assigned a point value and higher scores equating to higher grades. While in the modified Healy and MSK grading system, a tumor is graded based on its predominant morphologic features with certain histologic parameters characterizing a particular grade. The MSK grading shares some similarities with the modified Healy system in that it takes into account predominant growth pattern, but for high-grade MEC, criteria becomes more discrete with the mitotic count and tumor necrosis. So, the modified Healy system, low grade, you'll have macrocyst, microcyst transitions with excretory ducts, differentiated mucin producing epidermoid cells, often in a 1-to-1 ratio, minimal to moderate intermediate cell population. You can have daughter cyst proliferation from large cysts, minimal to absent pleomorphism, rare mitoses. You can have pools of extravasated mucin with stromal reaction, and no macrocysts, few microcysts, solid nests of cells, large duct not conspicuous, slight to moderate pleomorphism, prominent nuclei and nucleoli. In high grade, you'll have no macrocysts, predominantly solid, but maybe nearly all glandular. Cell constitution range from poorly differentiated to recognizable epidermoid and intermediate to ductal type adenocarcinoma. There's considerable pleomorphism, okay? And I'll leave these here for the rest of your review and reading. Okay, let's do multiple choice questions. All right, the most common fusion occurring in mucoep is CRTC1 mammal 2. Right. Which of the following is true? CRTC1 mammal 2 fusion may be seen in low, intermediate, or high grade. I believe that's true. Low grade MECs show high level copy number alterations. Low grade MECs typically show TP53. No, you would see that in high grade. So I think it's A. Yep. Entities that enter the differential diagnosis of low-grade mucoep, we talked about this. It could be a wart-thin tumor with oncocytic or squamous metaplasia. C. Entities that enter the differential diagnosis of high-grade MEC include, so it's scary looking, right? It's solid, predominantly solid, so it's not going to be a cyst adenoma, it's not a mucocele, not a sclerosing sialadenitis, because there's not as much inflammation. So it'll be salivary duct carcinoma. Mucoeps of the head and neck most commonly occur in I think it's the parotid gland. Yeah. All right, well, thank you so much to UPMC for this case, and I will see you next time.